to give this talk, even though I'm a trainee. Just passed the FRCS, that's the only reason. Yeah. What I want to do is tell you what you need to know and why. Where do you find the information for to pass the breast sections of Part 1 FRCS? How do I prepare for Part 1, if you're interested in that? And I will mention Part 2, but basically for Part 2, if you're not breast, it shouldn't come up unless they go bonkers for some of the sections. I have got a big disclaimer. I passed Part 1 in February, Part 2 in May. What I'm going to tell you is a mix of my own notes that I've dug out from preparation for FRCS. I do mention quite a few books and online resources, and I've referenced where able because I actually found my notes and some of them didn't have references. And I was like, where did I take that from? But it's reliably in some of those big bits that I mention. This is completely my impression of what is important and what I came across, especially in Part 1, and vaguely representative of the curriculum. It is by no means exhaustive. I've got a last slide at the bottom where I was like, actually, I didn't mention these bits, but I've got 77 slides, which is quite ambitious and could be very boring. Yeah, so I've given James the PDF to distribute to you because I know people study in different ways. How many people are online, James?
So we have 27, I think.
Okay, cool. I wonder if do we know the levels of those people? Is it people who are about to are preparing for the FRCS?
I think there's a big mix. So
okay.
There's a couple of ST3s running all the way up.
Okay, so I'm really glad to hear they're ST3s because the earlier you start, the better. And that's just general advice for FRCS. If you are on a job that you don't think you'll end up doing as a grown-up or towards the tail end of your training, it is worth investing in studying at that particular point for that particular specialty, because breast is not individual in terms of specialties you don't get exposed to. Same goes for HPB, transplant, endocrine. So yes, just a little aside. And considering the wide range of trainees, how many have actually looked through the curriculum to what you need to know? I went through the curriculum and put breast in the search box. So you need to be able to, it's in the general surgery curriculum, the document you should know, or have in your folders to be able to search, oh, is that in there, and things like that. You need to know genetically determined diseases related to breast, endocrine, GIT, basic principles of surgical oncology, and knowledge of risk factors, basics management, ways of evaluating cancer treatments, how MDTs work, and that's quite crucial to how we work in breast. In terms of technical skills, and these are levels for phase 1 and phase 2A, you should know how to have done this, even though you may not be exposed to a breast job. How to do a punch biopsy, evacuate hematomas of different, general surgical sites, how to do FNA of the breast. Yes, so that's the breast bits there. Be competent in diagnosis and initial management of breast sepsis, including sepsis associated with implant surgery. Drainage of superficial sepsis, aspiration of breast abscess, open drainage of breast abscess, and removal of infected breast implant. This is all, so you have to know it to be able to do it up to the level of ST6. And technically you should have evidence in your portfolio as well, apparently, according to the curriculum. In terms of assessing breast and axilla, should be competent in assessment of men and women with breast symptoms. There is mention of, again, breast infections, sepsis, soft tissue necrosis, acute and chronic complex wounds, and oncoplastic and breast reconstruction procedures, and implant salvage. And this is, so I'm pretty sure that it's different levels depending on what you're going to do as a grown-up general surgeon. But you need to know the basics in the phase 1 of ST training. So before subspecializing, the columns relate to early specialty training, then phase 2A and subspecialties. So yes, I have to know to different level of in terms of the implant salvage, but everyone has to know the breast infections bits. In terms of breast cancer competency, so these are again this asterisks are in the basic bit, early specialty training. So everyone has to know it for the FRCS. Be competent in assessment and management of all breast cancer presentations and treatment, including screening. Competency in assessment and management of those increased risk of breast cancer. And then in terms of principles of oncoplastic breast surgery, have knowledge and assessment limitations and risks of patients undergoing oncoplastic and reconstructive surgical procedures. A little bit more again about implant-based reconstruction and autologous reconstruction. It is to different levels, but everyone has to know something. Technical skills, again, so this is the evidence levels you have to have in your portfolio. There's bits on nipple surgery, and then so I think that's basically if you've been on a breast job, you have to demonstrate, you know, these are the WBAs you're putting in, and I have to know them to different levels than you, or demonstrate performance, obviously. And then in terms of the operative parts, it depends whether you've been exposed to the breast job or not. And in terms of the advanced oncoplastic skills, that is for breast trainees. Yeah, that's all in the curriculum. I am going to generally divide the talk into breast cancer, review of physiology, anatomy, a little bit into the assessment, surgical treatment of the breast and surgical treatment of the axilla, and then a little bit about adjuvant treatments, and then I'll have a little pause, possibly after the bigger sections to answer questions, and then I have a little bit about benign breast disease, because benign breast disease comes up in part 1. When it comes to breast cancer, this is probably one of the most important pieces of resource that you want. It's the NICE guidelines on the early and locally advanced breast cancers diagnosis and management. If you are going to read one thing in preparation for part 1, and please don't do that, do read more. This is probably one of the, this has the evidence and what we do for early breast cancer. In terms of guidelines, apart from NICE, Association of Breast Surgery, and this is a screenshot how to get into it, has quite a few free resources, and then if you're a member it has a little bit more, but in terms of the basic guidelines, they are free. This is the main website. You go into professionals, clinical, and then in the clinical you've got guidance platform, and in those you will have a lot more than that. It goes down to other bits like yeah, there's more after that. There's quite a bit on benign breast disease, but if you click, if it's a small enough topic on endocrine therapy or radiotherapy, there's going to be a separate PDF in those guidelines. And if you have any more interest than just basic, or even want to get a little bit of understanding, this is quite good. The specialty companion. I mean, I know some of you will like books. I would say that chapters 1 and 4 of the breast surgery specialty companion are very high yield, and the rest of the book is also high yield. But that's probably for the breast trainees, and also maybe snippets from different chapters if you are unsure or why did a certain thing come into breast disease management. All the evidence is in there. Quite a lot of evidence is in there because it was 2018, so there's some newer things are not, but very new, tiny little things. So if you And these are the specialty companions are available free from medical libraries as PDF. If you want a hard copy, worth an investment as well. It just depends on how you study. Yeah, I don't think you'll. I just told you to read the book, but no, the first 4 chapters are pretty good. And all the benign stuff is actually in 1 chapter, even though it's quite highly represented in part 1. It's only 1 chapter in the specialty companion, so probably worth reading. One of the bigger hit tips that I got, and especially this is for more junior trainees, because if you're sitting next month, you'll be like, you want me to read another book. But if you're going into the phase, if you're starting to plan for study for FRCS, I was helping Viva, a friend, a year before I start part 1, and I was asking her questions from the book, and I pretty much read the book with her. And a lot of the information for part 1 is in the cracking book. So if you were to get it for part 1 and use it on a train commute, bus commute, there is the information is there as well. It's not just a part 2 book. And I prefer Zoom actually, because you can get hands up and stuff. But has everyone heard of this resource on the RU group? Really good mind maps. And when it comes to benign breast disease and breast cancer, there's 2 specific mind maps. They're quite big, a lot bigger than some of the bits, but quite well done. Can give you, if you study that way, that's a pretty good resource, and it can give you the basis of what you need to read up on if you're that way inclined. And then the chemotherapy actions and chemotherapy regimens mind map is also pretty good, because it has the breast cancer standard chemotherapy regimens in it. That's my resources. Is there any questions on that or comments? Okay, I'll carry on. I'll review breast anatomy, because you just don't know, some of the complications of breast surgery will relate to anatomy. And if you know that, you can answer a question on part 1. Blood supply to the breast, 60% is from the internal mammary artery, which is also referred to anatomy books as internal thoracic artery. It's a branch of the subclavian, and it is interchangeably used, in case you're like, what? Is that the same vessel? Yes, it is. There's quite a bit of collateral from the lateral thoracic, from axillary artery, posterior intercostals, and anterior intercostals, which is really important, because what we do and how we do it allows us to do it because of the blood supply. The breast lies within superficial fascia of anterior chest wall and is separated by from skin by a layer of superficial fascia and subcutaneous fat. It sounds really basic, but that's what allows us to do skin sparing mastectomies and use that for reconstruction. There are about 15 to 20 duct lobular units that open individually onto the nipple areola complex. Suspensory ligaments of Cooper are fascial bands that run deep, from deep layer of superficial fascia to the skin, and it is a very highly vascular organ. It is a modified sweat gland of ectodermal and mesodermal origin, and you just don't know when that embryology will come into a question. The female breast is under a constant influence of autocrine, which is systemic hormones, and paracrine growth factors and cytokines, modulators of growth and development. It is really important to know that it is microscopically composed of glandular epithelium, fibrous stroma, and connective tissue surrounded by fat. Because of those 3 components, this is where the tumors originate from, and that's why there's quite a lot of confusion behind phylloides. But if you know that, you can probably work out some of the questions if you remember your basic origins in anatomy and physiology. Relative amount of each of those tissues is under control of circulating hormones. Therefore, it will vary according to age, menstrual cycle, pregnancy, parity, and breastfeeding. And the clinical considerations are different during puberty, in pregnancy, lactation, and perimenopause. Breast cancers, when we talk about the standard breast cancers, we're talking about malignant proliferation of epithelial cells, and non-epithelial tumors of the breast include sarcomas, lymphomas, and phylloides, mostly. Appreciation of the skin line creases of Kreisel and Langer's descriptions allow for optimal skin incisions. Skin and subcutaneous fat are separated by a relatively avascular plane, and this is our oncological dissection plane. It is we either use sharp dissection with scissors or diathermy, but there's also some surgeons will also use hydrodissection with saline or adrenaline mix. And thickness of the skin flap varies significantly, but this is crucial for skin sparing mastectomies because the blood supply to the dermal plane is what allows for skin sparing mastectomies, and maintaining that is what we would do reconstruction on. Removal of the deep layer of enveloping superficial fascia that encompasses the breast is recommended to optimize clearance of posterior margin. This fascia is separate from the pectoral fascia, which can and should be left intact as there is less postoperative pain, asterisk, unless it's involved by a tumor. If you find that at surgery, you just remove it. A little bit more pain post-operatively, but priority is oncological clearance. The inferior lateral extension of the breast, which corresponds to the upper outer quadrant, has the greatest proportion of glandular tissue, hence increased incidence of breast cancer in that quadrant. That relates again to how the breast develops and the embryology. Reduction of the ptotic skin envelope is a useful technique, both in aesthetics and when we utilize therapeutic and symmetrizing procedures. And ptosis is this. Grade 1 ptosis is where the nipple is at the line of inframmatory fold. It should normally be somewhere in that, it should be higher. Grade 2 is when you've got nipple below inframammary fold, but it remains at anterior pole of the breast. And grade 3 ptosis is where there is nipple below the inframammary fold, well below, and with nipple well below the anterior pole of the breast. In terms of the anatomy of the axilla, description of the axilla, the medial wall of the axilla is formed by the ribs and chest of the wall muscles, notably serratus anterior, over which runs the long thoracic nerve. Posteriorly, you've got subscapularis, teres major, latissimus dorsi, and over which run the thoracodorsopedicle, and pectoral muscles lie anteriorly. In terms of the complications that you're going to be asked on part 1, this relates to these 4 nerves. Long thoracic supplies serratus anterior. Damage to this is going to be winged scapula. Well, lateral pectoral nerve supplies pectoralis muscles. There's quite collateral blood supply, so you shouldn't get pec major wasting, but this is described as well with the medial pectoral nerve, which supplies the pectoralis as well. And then thoracodorsal nerve is nerve, and then the bundle around it, the artery and the vein as well, supplies the latissimus dorsi. It is absolutely one of the key bundles to isolate, protect, and not damage in a clearance, and also to potentially preserve for further therapeutic reconstructive options with a latissimus dorsi flap. In terms of lymphatic drainage of the breast, which we'll reviewing because it does link significantly into staging of the axilla in breast cancer. It is primary channel of metastasis in breast cancer. All 4 quadrants of the breast drain into a unit of a few common nodes into the axilla, which is the sentinel node. And the sentinel lymph node biopsy is based on the hypothesis that the breast drains as a single unit to very few common nodes in the axilla, thus disseminating tumor cells need to colonize these first before involving others. 10 to 15% drain primarily into internal mammary lymphatic chain, and often you will also have both, which is why it's a relatively reliable way of staging. There are many classification systems to distribution of the lymph nodes in the axilla, but this is the surgical one. And unless level 1, 2, and 3 have been cleared, anything else less than that is not a full axillary clearance. So level 1 nodes are lateral to the lateral border of the pec minor. Level 2 are beneath the pectoralis minor, and level 3 are infraclavicular, medial to the pec minor muscle, up to Halstead's ligament, and which is a dense condensation of clavipectoral fascia extending from the medial end of the clavicle to the first rib. Questions on that? Hopefully not. Shouldn't be completely new to anybody. Right, breast cancer, and quite a few of these, but this slide isn't, but the bits after this are from the first few chapters, I think chapter 2 or 3 of the specialty companion. Almost 75% of all breast cancer, in terms of ductal and lobular epithelial type breast cancers, are estrogen receptor positive and HER2 receptor negative. ER positive, HER2 positive constitute about 10%, ER negative, HER2 positive about 5%, ER negative, HER2 negative 11%. In terms of histological patterns, there are more than 20 special types, and that's our pathological gradings. Invasive carcinoma of no special type constitutes 60 to 80%, depending on which database you look at. And this used to be called invasive ductal carcinoma, and it's still used interchangeably. But in terms of pathological descriptions, invasive carcinoma, no special type, that's what we talk about. In terms of other pure special types, they constitute between 15 and 20%. We're talking about lobular, tubular, mucinous, and others such as micropapillary. And there's mixed types as well that can be described in a pathology report between 5 and 25%. When we're talking about grading, that relates to another pathological grading of what the nuclei are like and what they're doing. There is a score for degree of tubule formation, nucleopleomorphisms, and number of mitoses. And the grade 1, 2, and 3 in level of severity, in terms of that, if you have a lot of pleomorphisms, a lot of mitoses, and not much tubule formation, that's going to be a grade 3, cancer cells getting out of control. Yes, so tubules are good. Grade 1 will have quite a lot of tubule formation, more likely to be uniform cells, and not very many mitoses. Grade 2 is in the middle, and grade 3 is not going to have many tubules, a lot of mitoses, and the nuclei are abnormal. Why I mention this is because it does help answer some of the questions potentially in FRCS, especially if you're asked a question, would you refer that particular patient to chemotherapy, to neoadjuvant chemotherapy before surgery, for example. In terms of DCIS, I actually haven't been able to do that much in this talk, but DCIS is basic ductal carcinoma in situ, and the cells have not crossed or the invasion have not crossed the basement membrane. It is thought to originate from terminal duct lobular unit. It has special gradings into low, intermediate, high grade, and this indicates behavior. We now think that low and high grade are actually two different, almost two different pathologies. Lymphovascular invasion, if you see that on the pathology report, indicates tumor in vessels. That is a bad sign. Immunohistochemistry is used a lot to determine what epithelial cancer you're dealing with. brown staining corresponds to antigen being present, therefore it's positive. We're talking about invasive versus benign mimics, looking at lobular proliferations. Hormone status and HER2 status are three basic things that have to be on a pathology report. Depending on the trust, PR is going to be automatically within the conclusion of the report or within the main body. If you're a breast trainee, you should look at the physiology of estrogen and progesterone receptor status. It can come up in Part B of the physiology station of the special interest surgery station, but I will not do it for Part 1. You can look it up yourselves. It's in the specialty companion. We also sometimes get pathologists to analyze PDL1, and Ki67 is used quite a lot in research currently in Poetic A, for example. It is a variable, quite a subjective measure which is why it's not used for every single cancer. It varies between pathologists and units. This, I think you have to know about HER2. Human epidermal growth factor, also known, so it's equivalent. If you see a question about this is all exactly the same thing. It's known as HER2, ERBB2, HER2 NOI, or CD340. They're talking about exactly the same thing. It is a tyrosine kinase protein present on all epidermal cells, not just breast. And it's dimerization of HER2 protein that results in activation of cell signaling pathways, which stimulate cell proliferation. And HER2 is overexpressed in 15 to 25% of breast cancers, and it is associated with more aggressive and poor disease and poor prognosis, though now we have a lot more treatments for it. HER2 overexpression is also associated with tamoxifen resistance in ER-positive tumors. And HER2 expression confers sensitivity to anthracycline-based chemotherapy agents, although this combination is associated with increased cardiac toxicity. But you may have younger patients who will have a HER2 positive disease, which may get this, which depending on their cardiac function may get that particular combination. And this has definitely come up in Part 1. You get a report of an ER-positive HER2 1+ patient, and you think that 1+ indicates HER2 positivity. It doesn't. If HER2 is calculated by immunohistochemistry, and if it's reported as 0 or 1+, that is negative. That's HER2 negative, and that's 2/3 of cases. 3+ on immunohistochemistry is definitely HER2 positive in 11.6%, and 2+ indicates equivocal or borderline HER2, which is initially it'll be in 21.7% of cases, but it's consequently tested with an in situ hybridization test, either chromogenic or fluorescent, to give you the final HER2 status. And initially, we often don't have HER2 reports, and you have to repeatedly check your pathology of the particular patient. We discuss them at NDT because that these tests can take a while. For example, we get ours done in Exeter, it gets done in Truro, so there's usually a bit of a delay. That's one of the big questions that will come up in Part 1. Reliably comes up. And I've come across it both in, I have a little flashback of doing that in Part 1 in Feb, and I think some of the question banks do have that question quite a lot as well. TNM staging is interesting because we don't talk about it to patients. Patients ask us about a stage. We cannot comment on the final stage of their disease until we've technically done the surgery, because axillary lymph node biopsies are part of the staging. The reason I have it in here is because you need to know certain things about the tumor even before you've operated on to know which way you're going in terms of treatment. And I had a little animation that I have actually crossed off the far right bit of the TNM stage, but for your understanding, it can help. So we've got in situ disease. T1 is basically anything under 2 centimeters, and that is important. That is proper early breast cancer. should be, if we're operating, we should be able to do breast conserving surgery. If you've got a T2, that's basically 2 to 5 centimeters. T3 is more than 5 centimeters. And if you remember that there is T4s, if they present, that's pretty much indicates, the reason that stage is important is that pretty much indicates stage 3, which is basically locally advanced disease. And I've got a flashback to a question from part 1 where they gave you so little information. That's part of the difficulty with part 1. They just said it was a 3 centimeter, ER positive, HER2 negative. What surgery are you going to do? And anything more than 2 centimeters is probably considered relatively big. I think I answered that question correctly with a mastectomy and simple mastectomy and sentinel node biopsy, but we will never know. And then if you've got extension to the chest wall, but does not include pectoralis muscle invasion only, you've got T4A, which can be picked up on a staging scan, for example, staging CT. If you've got ulceration, ipsilateral satellite skin nodules, skin edema, podrange, that's pretty much a T4 cancer. T4C is if you've got both A and B together, and T4D is inflammatory breast cancer, and that is basically considered, it's behaves differently. It tends to have very aggressive pathology, so that's why it's in there separately. In terms of nodes, PT1 basically is up to 3 nodes. PT2 is between 4 and 9 axillary nodes, and PN3 is not. It's when it's more than 10 involved nodes, and you will very rarely have, you will not have this until you've operated on the patient, and you will not have a PN3 until you've done a clearance, which not many patients get because treatment is changing. So that's why I wanted in there. Don't get bogged down. It's more about understanding and a few key bits of information from this. Do not memorize, but have a little bit of an understanding. In terms of breast cancer treatment, all the bits are in the NICE guidelines, like the basic why we do what we do in terms of the breast, in terms of the axilla, and then adjuvant treatments. They're all in that NICE guidelines. And even when I'm talking to a patient who has either come from screening with a small cancer or symptomatic, I will divide my consultation when I'm explaining the treatment to them about the treatment to the breast and treatment to the axilla, because the treatment to the axilla is first staging the axilla with sentinel lymph node biopsy, and then we have options of radiotherapy or clearance, which is the further treatments. I'll mention surgery briefly because it is key, but there is so many other things in breast cancer treatment. In terms of simple mastectomy, most scars are based around the inframammary fold, unless we have to adjust for a fungating tumor and you have to achieve oncological clearance. Patient is supine with the arm out. There should be adequate. So it's a mix between adequate tension versus not enough tension. Well, it just has to be right. So adequate tension, not too much, not too little. You will look at patient characteristics. If they're a smoker, type 2 diabetic, you may give the wound a little bit more give if the priority is to get them healed rather than a perfectly flat chest. And a mastectomy, even a simple mastectomy, is not 100% removal of every single breast cell. It is about 95 to 96%. And occasionally you get patients asking that question, and this is what it is. Radical mastectomy still has a role to control locally advanced disease, and this is where pec major is removed, which it's not in simple mastectomy. In terms of breast conservation surgery, so this is when you're thinking about basic breast surgery, this is the wide local excision. Breast conservation surgery has equivalence in terms of disease outcomes compared with mastectomy, as demonstrated in 2 systematic reviews. An acceptable cosmetic appearance, it's with simple level 1 breast conserving surgery, acceptable cosmetic appearance is possible for majority of women with breast cancer. There are fewer complications and it is most cost effective than mastectomy. There are lower levels of psychological morbidity compared with a mastectomy, with less anxiety and depression, with improved body image, sexuality and self-esteem. And we now have, there was a Swedish study published 18 months ago, population study, has some problems with it, but it's demonstrated that patients with wide local excision, breast conserving surgery and radiotherapy did better than patients who had simple mastectomy with no radiotherapy over longer period survival time. There are confounders because it's a big population study, it's not very well controlled, but there is a theory that it's the radiotherapy after wide local excision that confers extra survival advantage, but it's not been proven in a randomized controlled trial, as it can't be. But there is that study out there as well for those more interested in breast. Look it up. In terms of wide local excision closure, it is in a radial parenchymal closure. So basically think of it as a clock face, and we can mobilize the tissue under the skin and then move it in the right radial way. Oncoplastic techniques are important, and even a simple wide local excision should be utilized in all breast surgery. Some patients will benefit more than others, and that's with patients with large tumor to breast ratios, basically more than 5 to 10% in superior, medial or inferior quadrants, and more than 20%, you can get away with a lot more laterally, which is your upper outer quadrant, which tends to have a lot more breast tissue because of anatomy. You will, when you're making decisions about what to do, you will consider patients who are at risk of margin involvement, such as patients with DCIS, invasive lobular, but younger women or larger tumor size. And there are those at high risk of poor cosmetic outcomes with mastectomy and reconstruction, because of you can not always predict, but you can identify certain disease patterns where you will think of a patient needing radiotherapy after their mastectomy, such as lymphovascular invasion, such as tumor size, large BMI, need for axillary lymph node clearance. And for some of those patients, there may not be a good or accepted reconstructive options. And then we scratch our heads and have oncoplastic MDT discussions and look at options. In terms of margins of excision, this I could see this coming up as a question, because you may have a patient come back to your clinic, had a wide local excision, and the margin is 0.2 millimeters. What are you going to do? In terms of guidelines, so this bit on the left is from the main NICE guidance, and technically they say, so offer further surgery, which is either re-excision of margins or mastectomy as appropriate, depending on patient size and available tissues, after breast conserving surgery where invasive cancer or DCIS is present at the radial margin, which will be reported potentially as tumor or ENC as well, or 0 millimeters. And that tends to be quite black and white. You go for more margins. And that has not been cleared. That disease has not been cleared, and it has a much higher rate of local recurrence. For women who have had breast conserving surgery, this is NICE guidance on the left. Breast conserving surgery for invasive breast cancer or DCIS, if it's within 2 millimeters, but on the radial margins, you will discuss benefits of and risks of further surgery to minimize the risk of local recurrence. But this says in guidance, take into account women's preferences, comorbidities, tumor characteristics, and potential use of radiotherapy. ABS, our Association of Breast Surgeons guidance is 1 millimeter. And the difference between 0, 1, and 2 is based on the number of trials. If you're going for part B in breast, you will be looking at that evidence. For the general surgeon, if it's invasive cancer or DCIS at the radial margin, your answer for that question is going to be go for more. If it's 1.8 millimeters, I hope that the answer is going to be discussed with patient rather than straight for surgery. You have to look at the patient, the available breast tissue remaining, their preferences. It's not black and white. And we use 1 millimeter nationally because of the ABS guidance. This point, nice recommendation, because it's because of that quote there, depending on women preferences, comorbidities, tumor characteristics. And if we have done breast conserving surgery for invasive cancer, radiotherapy in an adjuvant setting goes hand in hand. And it's because we know that it decreases the risk of local recurrence. In terms of oncoplastic techniques, we talk about level 1 and level 2 procedures, because level 1 allows up to 20% of breast volume to be excised, and level 2 techniques is where we're looking at complex mammoplasty or volume replacement techniques, where you bring tissue from somewhere else. Principles are to maintain breast form and shape, perform the simplest procedure that gives an acceptable result, only perform techniques within your own skill set, do not compromise on wide local to facilitate better cosmesis, because positive margin has no place, and choose safety over perfect cosmesis. So we're talking about oncological safety, and aim for all necessary surgery to be completed at one operation, which is why, and including symmetrization where we have bilateral surgery, though that depends on the trust. And this is to decrease the risk of needing further operations. Actually, what I meant to say was on the previous slide, when we're talking about radial margins, that's your superior, inferior, medial and lateral. Anterior and posterior are not radial. And if they're close, that is all the surgery we can do, because normally when we talk about the anterior, you're going to be in the oncoplastic breastplane. So even if if anterior is within 0.2 millimeters, but it's not invaded past that, technically you're clear and there's no more breast tissue left, because if you've been in the right plane. And posterior indicates that we have been onto the two fascias that separate the breast from the little prepectoral fat and then the pectoral fascia. So it's not the pectoral fascia, it's the fascia that invests the breast. And that's why review of the anatomy I thought was key. So just note that we're talking about radial. So if the question says posterior is 0.3 millimeters clear and inferior is 0.1 millimeter clear, if there is an option of which margin to clear in that question, I would choose re-excision of inferior margin only. You will not be able to get more posterior, because technically if you're in the right plane, you then have clearance. I hope that makes sense. Does that make sense? If not, put a question in the box. In terms of oncoplastic techniques, I'll just mention this. Hopefully won't come up it'll be tricky to ask these questions in part 1. But when we talk about volume displacement techniques, we're talking about simple parenchymal advancement into the defect, round block, which is in the picture there, where we basically take some. Is someone's microphone on? Question? This is pictures of round block with nipple centralization, therapeutic mastopexies, and therapeutic reduction mammoplasty. That's where we displace, so move some of the volume around the breast. In terms of volume replacement, it would indicate that we're replacing it from somewhere else, so it has to come from somewhere else. This is where we're talking about chest wall perforated flaps, such as lateral intercostal artery perforated flap. If you recall from anatomy, it's those tiny little perforating vessels coming from the intercostals. They supply subcutaneous fat and dermis and the skin that we can move and replace some of the tissues whilst maintaining that tiny little perforating vessels. Because patients, for example, on this is an L tab. Yes, I think that though it's from a book. The pictures are from a book. I think they're quite high actually, but it involves removing all of this tissue away, de-epithelializing, leaving dermis subcutaneous fat, and rotating it in, where this is this. Then there is usually you pick the patients appropriately to then close that skin, is scar left over, and that tissue flops into the defect. Potentially, a whole quadrant of tissue may have been removed from the breast. An LD flap is considered a volume replacement technique. Thoracodorsal perforating flap, and then free flaps are less commonly used for partial breast reconstruction, more commonly used for whole breast reconstruction following a mastectomy. And this is, so the chest wall perforated flaps often, apart from the LTAP, all of these rely on the perforating arteries from the intercostals. And if a patient has had wide local excision of a lot of tissue with a chest wall perforated flap, they will get radiotherapy because we have kept their breast tissue. So that's a little bit about the breast, and now I'm going to move on to lymph nodes, because the sentinel lymph node biopsy testing is quite reliable, and it's part of staging to tell you how many lymph nodes are involved and what else does the patient have to get. When the question talks about isolated tumor cell clusters, these are single cells or cell clusters, either measuring less than 0.2 millimeters in size or amounting to less than 200 cancer cells in one lymph node section. Technically, isolated tumor cells are not a positive lymph node. Same goes for micrometastases, and it's up to 2 millimeters max, or more than 200 in a section, but not more than 2 millimeters. And macrometastases, these are positive lymph nodes. They measure more than 2 millimeters in maximum dimension. And I think it will be a mean question, but it can't, it's in the curriculum, it could come up. I think I've seen a question in a prep database. I can't remember if it came up on the actual exam. But if you were told in the description of the question that you had 2 out of the 3 sentinel nodes had macrometastases, which treatment would you consider? That could be a potential question. And you would then consider either radiotherapy to the axilla or clearance, depending on some other features, which is quite a mean question. But if one of those 2 is an option, that's what you would do. And at the moment, clearance would be ahead of radiotherapy with the amount of evidence we've got. But radiotherapy to the axilla alone without surgery is there for patients who would qualify on AMOROS trial type characteristics. In terms of whole breast reconstruction, I'll just mention this. It's tricky to get this involved in part 1, but NICE guidance says anyone with a mastectomy should be offered a reconstruction, at least discussed. And a lot of the time you mention it to the patient and they don't want it, but you have to at least mention it. We talk about immediate versus delayed, autologous versus implant, nipple sparing versus nipple sacrificing, skin incision choices. We discuss every patient at Oncoplastic MDT. We have specialist reconstruction nurses to help us educate patients. It tends to involve complex decision making. A lot of patients will have more than one option, and there's a lot of preoperative planning and marking. I felt that I need to mention it. It'll be tricky to answer part 1 questions, but oh yes, the reason to mention is because we do use quite a lot of implants. The proportion of autologous versus implant will depend on the trust, will vary across the trust. There is some postcode lottery. It'll depend on patient characteristics, operative experience and level of skills, just so many things. But you have to know there could be a question about breast implant associated anaplastic large lymphoma. For example, a patient with existing implants in place, whether aesthetic or reconstructed, comes with a seroma 8 years down the line. And the question is, with your investigations, what are you looking for? And that's the answer. It is a rare subtype of T-cell non-Hodgkin lymphoma, one of 4 subtypes of ALCL which have been found in association with breast implants in a small number of cases worldwide. It is a subtype that is always both CD30 positive and ALK negative. If they're mean, they could put those 2 things in there in the description of the question. According to 2021 data, at the time there were 88 confirmed cases in the UK, and I went to a meeting in June that they're still quoting this number. I don't have an update on that. There were 6 cases of non-UK implanted cases and 82 UK confirmed. 61% were in aesthetic implants alone, and 33% are in reconstructed neobreasts. At the moment, the incidence we're quoting when consenting is 1 in 15,900, but rounded up, it's somewhere between 1 in 12 to 18,000. There is a unit in the States that has 1 in 6,000 because they've been doing so many aesthetic implants. Peak year of diagnosis was 2017, where there were 22 diagnoses. 2020 had 7, 2021 3. And most common presenting symptom, unilateral idiopathic seroma. And there is a protocol for investigations and treatment, which I would think is for breast trainees only rather than part 1. But it revolves around taking out the implant in the capsule. And I think 1 or 2 patients out of the, actually, no, I'm lying. But a handful of patients needed more than just surgery with chemotherapy. It was single digits as far as I remember. Surgery to the axilla. When we're talking about, if you see a patient that has an invasive cancer in the description of the question and what surgery you're going to do, if it's invasive, you will do a sentinel lymph node biopsy. Whatever option has what you think is the appropriate surgery to the breast and the axilla needs to include a sentinel lymph node biopsy. Unless it's a heavily positive, heavily involved axilla at diagnosis, which you will clear. So quite mean if that comes up. In DCIS, if you're doing wide local, you do not have to stage the axilla. That is not invasive cancer. But if you're doing a mastectomy for DCIS, so if it's 80 millimeters of DCIS on imaging, you're going for a mastectomy, you will do a sentinel lymph node biopsy. That's in the guidelines because you cannot go back. There's no, if you take all the breast tissue, there's no further breast drainage, lymphatic drainage into the axilla. So that's the reasoning behind it. SNB is a key prognostic factor. It is part of staging. We sample up to 4 nodes, and that's because of the risk factors of lymphedema and because of the there was anatomical analysis done when this was developed. We don't need to take more than 4 because of how breast drains into the axilla. Traditionally, so in terms of the initial SNB trials, it is a dual technique of technetium-99 and patent blue dye. But there is more evidence that some units are going away from dual technique. I would stick to dual for FRCS because there's no big trials that are suggesting we should be going single just yet. In some units, they're now using mag trace with technetium. So, but it shouldn't be on part 1 of FRCS. If they do that, that's quite mean. But false negative rate is less than 10%. And SNB alone, even if we take up to 4 nodes, still carries a risk of lymphedema between 5 and 8%. At consent, I usually quote between 6 to 8%. For SNB. So patients do have to be fully informed, and occasionally you will get a patient who will say no to SNB. When we talk about axillary lymph node clearance, that is the same thing as axillary lymph node dissection. a full clearance will involve clearing all the lymph node tissue from levels 1, 2, and 3. It does not improve survival from breast cancer for node-positive patients, but it can decrease rates of local recurrence significantly, which is why we do it. Lymphedema rates between 25-30%, depending on who's quoting. There's going to be limitations in post-op shoulder and arm mobility. All our patients get early exercises and they move through an exercise program. There can be prolonged post-operative pain. There can be cording, which is also called Mondor's disease, and there can be paresthesia. There are so long thoracic nerve of Bell, thoracodorsal, and the ones that we definitely don't want damage. Sometimes you'll have them encased in the lymph node, in positive nodes, so then you make a decision intraoperatively. Paresthesia comes from damage to the intercostal brachial. That technically is a small sensory nerve, but every patient gets, and a lot of the time it's going right through the dissection specimen and you cannot save it. It's a small nerve, and you inform patients of us that they may have a small patch on the inside of the arm that will not feel normal again. But if that's what you need to do to clear the disease, you have to do that. So you do inform patients of these complications. That is mostly what I'm going to cover about surgery, because there's so many other bits and breast cancer treatment. If I recall correctly, there were some questions about, would you send this patient for neoadjuvant chemotherapy? And it can come up because there are some certain cancers you will identify, and it's the more aggressive ones, ER negatives, that you want to see. For those interested, evidence for neoadjuvant chemotherapy came from NSABP, B18, B27, and then a meta-analysis of 14 randomized controlled trials that in operable breast cancer, and when we talk about operable, you're thinking back to the initial TNM staging, basically T3, mostly up to T3 tumors. There is no survival advantage to neoadjuvant or adjuvant chemotherapy. So if you can operate safely on the first stage, it does not matter for the patient's survival if you give them chemo before or after. And you will identify patients initially who you know will need chemotherapy at some point in their treatment journey. But several advantages have emerged from those trials in terms of identifying who will benefit from chemotherapy before their surgery. And it's patients had improved survival in those patients who achieved pathological complete response and pathologically node negative disease. And there were increased rates of breast conservation in patients initially planned for mastectomy. And now we know that breast conservation is better necessarily than mastectomy. We want to identify those patients because they may do better in the long run. General indications, and I think this is from the Specialty Companion. If you want to downstage from a mastectomy to breast conserving surgery, if you want to facilitate dual anti-HER2 therapy, if you've got inoperable disease or locally advanced breast cancer at diagnosis, if there is reduced planned volume of if you want to have reduced planned volume of excision, to facilitate genetic testing, because that will change, that can change the surgery we do. And if there is inflammatory breast cancer, that is one of the inflammatory breast cancer is one of the almost absolutes if the patient is fit. And this is hot off the press, very exciting stuff altogether from ABS. On the 6th of September, there was a webinar because the Association of Breast Surgery has just released a guidance for neoadjuvant chemotherapy, because there's quite a lot of variation across the country in terms of a lot of things, actually. And there's a bit of a postcode lottery depending on the unit. So there's this guidance. It can be found on ABS website. But if you have, in the question, this can come up. If you have a HER2 positive or triple negative breast cancer and it's more than 2 centimeters, or has positive nodes on ultrasound imaging to the axilla at diagnosis, these are if there is an option of 4 surgical options in neoadjuvant chemotherapy, the answer to that question is going to be send the patient to oncologist for neoadjuvant chemo. If it's a small HER2 positive or triple negative, so T1b or T1c with negative nodes, you would not necessarily rush them off to neoadjuvant chemo, but you will consider it if for example, it's a small breast, and if it's needed to facilitate breast conserving surgery or to allow for germline testing, genetic testing, because it can change. If it's a small triple negative in a 35-year-old woman, there is a good chance she might be BRCA positive. She actually does not need breast conservation. If she's BRCA positive, she needs bilateral mastectomies. That's the reason for that bit of the. That's the reason for that line. And if it's an ER positive, HER2 negative cancer, you will only consider neoadjuvant chemo if it's a high risk disease in premenopausal women to try and facilitate breast conserving surgery, germline testing, or to allow time to plan breast reconstruction. And breast conserving surgery will not be possible in every single patient because there is a difference between the invasive component of the disease versus a lot of microcalcification on the initial mammogram. Microcalcification will not respond to chemotherapy, but that's for decision-making for senior breast trainees. And if an appropriate trial is available, because there is more stuff coming out, there's more non-traditional chemotherapies coming out for ER-positive patients. Avoid neoadjuvant chemo if full surgical pathology or genomic testing is required to inform decision about decision-making about chemotherapy. And NET is neoadjuvant endocrine therapy, should be considered in postmenopausal women for downstaging to facilitate breast conserving. So in a question in FRCS, it'll depend on the age of the patient. They shouldn't give you, and that relates to how likely they're going to be pre or postmenopausal. It would be very mean if they give you someone 52 years old with a tumor in between size. But for FRCS part 1, it should be quite clear, because if you've got a 3 centimeter HER2 positive or triple negative, they'd benefit from neoadjuvant chemo. If it's a 72-year-old with a 15 millimeter ER positive HER2 negative, you're going to chop that out. And they're actually quite unlikely to need chemotherapy altogether. In some units in the country, neoadjuvant endocrine is used quite a lot for larger cancers, 5-6 centimeters. Give them 6 months on endocrine therapy to try and shrink them down to try and facilitate breast conservation, if the patient's keen. This is, in terms of once you've operated, this is one of the things that will come up in part 1. You can reliably expect at least one question about calculating Nottingham Prognostic Index. Practice, get the calculation down, very easy marks. And it is quite old. It was developed in the 80s, and we now have a lot more advanced prognostic markers to aid decision-making in terms of adjuvant therapies, but it still comes up in FRCS, and it has been very well validated. So if you've got an NPI of up to 2.4, their 5-year survival is 93%. It then goes down to the good prognostic group to 3.4, 85% 5-year survival. You've got the moderate prognostic group who will get quite a lot of adjuvant things offered to them, as they have a 70% 5-year survival, depending on the biology of the cancer. And you've got poor prognostic group and very poor prognostic groups that will have, if they're fit, they'll have everything thrown at them to improve their survival with adjuvant therapies. Apart from, so NPI, really important. It will get reported on any cancer at the final histology. But we will also use other tools. One of them is NHS Predict, as it predicts survival following surgery for invasive breast cancer, and it's based on a UK dataset from Eastern Cancer Information and Registration Centre. It includes method, so we put so much more into NHS Predict than we do into NPI. You can do it online, and it includes method of detection. So basically, did the patient come from screening, or was it a symptomatic presentation? The HER2 status of the cancer, grade, tumor size, number of positive nodes, ER status, and patient age. Actually, and now that I think about it, I wonder if there could be a question on part 1 asking you which one of the following is not part of NHS Predict. There's other calculators such as Adjuvant Online, Predict, and Cancer Math, and they have significant advantages over the NPI through integration of effect of adjuvant treatment from Oxford Review to the breast cancer specific mortality. So I've done a little calculation on an imaginary patient on Predict. So they had invasive cancer, they were 55 years old, somehow had managed to go through all of her menopause. So menopause technically is defined as you have to be 2 years without a period without further menopausal symptoms to be considered postmenopausal. If there are any women who still get an occasional bleed, they will be considered perimenopausal, and that does make a difference to our oncology colleagues in terms of the treatments they can offer and how they're likely to respond. ER status, HER2 status, Ki67, often unknown, and that's okay. The final measure of the invasive tumor size, tumor grade, how it was detected, and how many positive nodes on sentinel lymph node biopsy. I hope you can appreciate why I've mentioned all of those basic things, is because that's the basic understanding into some of the things we do. So basically there you click on all of that and you get treatment options and results and how different treatments will affect that patient. So if she gets no hormonal therapy, no chemotherapy, and no bisphosphonates, 10-year survival with surgery only is pretty good, 87%. But if she were to get 5 years of hormonal therapy, which she would probably get, chemotherapy, unlikely, but I clicked it there. And if she were in a unit that would offer her bisphosphonates, the hormonal therapy would have an additional benefit of 2.2%, chemotherapy 1.7%, and bisphosphonates of 0.5, which is why she would actually probably unlikely to be actually offered the chemotherapy and bisphosphonates by the oncologist. But if the patients ask the oncologist why I'm not being given chemotherapy or even offered, it's because the absolute benefit is not that high and the risks are there. And in terms of the chemotherapy question, second generation chemo is basically anthracycline containing, and it's more than 4 cycles of equivalent. And third generation chemo is toxin based. So that's why you need to know that. There are now also other things in terms of what's available in an adjuvant setting. And this delves even deeper. So if you appreciate that Predict goes on very standard measurements of breast cancer, or very standard characteristics of breast cancer. We're now looking at genomic sequences of different cancers, which is what the EndoPredict test is, Oncotype DX and ProSigna tests. They're recommended as options to guide adjuvant chemotherapy for patients with estrogen positive, HER2 negative cancers and lymph node negative cancers, because they look at genetic qualities of cancers, and we have now got some evidence that we know that certain cancer is more likely to respond better than another when they're ER positive. This is directly from Oncotype website, and I think it should be for senior trainees, breast trainees only. If Oncotype comes up on FRCS Part 1, tricky, but I thought I'd mention it. It will be quite a mean question. Oncotype assesses individual tumor biology by measuring the expression of 21 genes, 16 cancer genes, and 5 reference genes. Some of the things that we use for the traditional PREDICT and NPI are there, but there's more. So you have Ki67 in the proliferation gene. This is all the genes in the different sections, but there's more stuff for proliferation, invasion, HER2, estrogen, and others. It gives you basically 3 results. It gives chemotherapy benefit, recurrence score between 0 and 100, and risk of distant recurrence. And the recurrence score is interpreted along with menopausal status because that helps oncologists make the decision of what's the benefit of different treatment options. This is on the Oncotype website, and where the evidence, when Oncotype was used in which patients and which trials. This is for specialty trainees, breast trainees. I'm not going to. You shouldn't. If you're interested, go on the Oncotype DX website. It was so the NSABP B14 and B20 trials is where Oncotype DX was retrospectively validated. Predicts adjuvant chemo benefit in HER2 positive, estrogen receptor positive, HER2 negative, node negative early breast cancers. We did not have this test for these patients before. And if you have a look, if that particular patient has a low recurrence score of less than 10, we now know there is no chemotherapy benefit. We don't have to put patients through that. But if they get a high recurrence score of more than 26, we know that they benefit from chemotherapy, and that's because they're likely to have, their cancer is more likely to have mutations in the proliferation and invasion parts, which would make sense because chemotherapy is more likely to act on those parts. There was a whole trial created for the intermediate recurrence score of 11 to 25, and that's Taylor X results, which you can look up as well. I've mentioned a few adjuvant treatments like radiotherapy for any patient with invasive breast cancer who has had breast conserving surgery. There's just so much more, but you have to know that radiotherapy goes hand in hand with breast conservation. Endocrine therapy goes hand in hand in a patient who has had estrogen receptor positive cancer. And bisphosphonates are there for patients with a high risk of the cancer coming back. I think it'll be NPI 3.4 and above, in which a lot of units patients will have at least a discussion about a bisphosphonate. And if you want more details, if you're a senior breast trainee going into Part B, you will be looking at those guidelines. These questions come off when we talk about endocrine therapy. This comes up often. And you're asked, it's basically mechanism of action of the endocrine medication. Tamoxifen is a non-steroidal anti-estrogen or a selective estrogen receptor modulator. Exemestane is an irreversible steroidal inhibitor, and anastrozole and letrozole are reversible non-steroidal competitive inhibitors. I've seen those questions quite a bit in prep. There is a lot more in adjuvant treatments for breast cancer. But if it's ER positive and you've saved the breast, it's going to be endocrine therapy and radiotherapy. And then it depends if it's HER2 blockade you're looking at as well. If it's a high-risk patient with positive nodes, at diagnosis, they're more likely to get chemo. So okay, I've got 10 minutes. So in terms of screening, screening does come up, especially in Part B for breast trainees. It can come up in Part 1 because you need to know how breast cancer screening works in this country. It is a woman is invited between. Actually, I GP registered women will be invited for breast cancer screening between aged 50 to 71 every 3 years. It involves 2 views of mammogram, medial lateral oblique and craniocaudal, and each patient's mammograms are double read. The major benefit is reduction in mortality for breast cancer. The major harm is overdiagnosis. For 10,000 UK women invited to screening from the age of 50 for 20 years, around 681 cancers will be found, out of which 129 will represent an overdiagnosis. The Marmot review was a huge review in 2012 for breast cancer screening, and the best evidence of the relative benefit of screening on mortality reduction came from 11 randomized controlled trials. Meta-analysis of these trials with 13 years of follow-up estimated a 20% reduction in breast cancer mortality in women invited for screening. This corresponds to 1 breast cancer death averted for every 180 women invited to attend screening. It is actually still quite controversial, and it is becoming more controversial because the benefit of mammography screening has been diminishing over time. And 3 most recent trials show no benefit at all. But this relates to a treatment interaction, because screening depends on treatment, not early detection. And as the treatment gets better, the benefit of screening diminishes. And it basically means that nowadays our treatments are so good, but the original evidence was reviewed in the Marmot review, and it is there. It had saved lives, and it had saved lives from breast cancer, and it still does. That's the population breast cancer screening. In terms of family history, genetic testing, and high-risk screening, there is a separate guideline for familial breast cancer, where you can look at the referral pathways, okay? But basically, it talks about when to refer to secondary care, and it's important because 15 to 20% of breast cancer will have of breast cancer presentations will have family history in them. So anyone who doesn't have any of these problems can be dealt with and managed in primary care. So these are kind of red flags in history taking. Patients with bilateral breast cancer, male breast cancer, ovarian, Jewish ancestry, in a patient who has had a sarcoma at a young age, less than 45, patients with glioma or childhood adrenal cortical carcinomas, or complicated patterns or multiple cancers at a young age, and paternal history of breast cancer. These patients are a lot more likely to be managed in family history clinics. Referral criteria, this may come up. It will be, but I'm pretty sure that it's similar to, you need to know the referral criteria for colorectal cancers, colorectal high-risk screening as well. So a first degree female relative, so these are patients who would be referred from primary care to us for example, the family history clinics. First degree female relative diagnosed with breast cancer when they were less than 40. If there is a first degree male relative diagnosed with breast cancer at any age. First degree relative with bilateral breast cancer where the first primary was diagnosed less than 50. 2 first degree relatives, or 1 first degree, 1 second degree diagnosed with any breast cancer at any age, or first degree or second degree. Yeah, it goes up. The more relatives you've got, you can look up the guideline. You know, if we were GPs and if that was the question, or if you're in a breast clinic as an ST3 or a 4, and a patient asks you, should I be monitored closely? You can see if they should be referred to a family history clinic. What I find really interesting, and what breast trainees should know, is there is high-risk screening and very high-risk screening. And one of the things that will make you more likely to need high-risk screening is for patients who have had radiotherapy to the breast tissue. the Christie Foundation Trust has developed a data set called Breast Screening After Radiotherapy dataset. And it's a confidential database for women in England who have received radiotherapy involving breast tissue when they were aged 10 to 35. They've got a much higher risk of developing breast cancer. And current national guidelines recommend that screening should start 8 years after radiotherapy to breast tissue, or at 25 or 30, depending on circumstances. So this relates to patients who have had lymphoma, a lot of lymphomas or sarcomas, who may have had chest radiotherapy. That's breast cancer, and that's not all of it. But that's what I thought I should go through. I think I'm going to power through and just mention the benign conditions. And then answer any questions into your lunch. The benign goes into pediatric and adolescent breast disorders, tube-based breast deformities, gynecomastia, fibroadenomas, which can be giant. And I almost did like a separate thing. It's not a disease, but as a symptom collation for nipple discharge, that may also be a separate question on the FRCS. So there's just no way I can cover everything. But it's a mention to look those bits up in the benign disease chapter in the book, in the specialty companion book. Fibroadenoma is very common, and it is basically if you remember of the 3 types of general tissue components of the breast, a fibroadenoma is a benign fibroepithelial breast lesion composed of both stroma and epithelial elements, more common in premenopausal women, and it will be present in as many of 10% of women's breasts. Natural history, and this does come from a big study that was done, suggests that 50% will resolve spontaneously, 25% will not change, and 25% will get bigger. Very few are likely to have atypia, in situ, or invasive malignancy, or in or adjacent to the lesion. And it's increase in size that concerns people, and it is still unlikely to contain an underlying malignancy, but undiagnosed phylloides is present in only 2.4%. We are most likely to take out fibroadenomas if the pathologist says we cannot fully exclude the phylloides on this core biopsy specimen. Because phylloides has an unknown etiology, but it is more likely to occur later than the fibroadenoma, on average 15 to 20 years later. It is a tumor that grows rapidly, sometimes producing marked distortion and cutaneous venous engorgement. And the aim of surgery in that case is to remove benign phylloides with a clear but not a wide microscopic margin. And it's not very common. So there's lots of little classifications, and there's no general consensus on classifications either, but basically they tend to be described into benign, borderline, or malignant phylloides. And they're difficult to distinguish necessarily between, for example, borderline or malignant, but it depends on assessment of size, ratio of stroma to epithelium, border of the lesion, stromal cellularity, number of stromal mitoses, and presence or absence of necrosis. And it is its local recurrence that is usually concerning in terms of malignant phylloides. They behave differently than epithelial cancers. Lymph node involvement is rarely seen in only about 5%. Only about 5% overall will metastasize, and that's when we take all of the phylloides together. But when you look at malignant phylloides, about 25% may metastasize, and this depends on the classification that is used. But metastatic spread is similar to that of sarcomas. And that's a picture from the specialty book. That's a reasonably late presentation as well. And there is no consensus. Well, there's some consensus. There is some investigations into how to manage them in a uniform way. There is ongoing research from Karolinska that is actually international, because we've recently done a survey on how we all manage them. different units, and that has not yet been published, but I remember submitting data. And someone said there were quite a few questions on phalloides in part 1, so I'm not sure if that's enough to cover that, but it didn't come up on my part 1 in February, but that doesn't mean that won't. And then breast sepsis is part of the curriculum manage, and it still will come in on general surgical take, and it will for the moment, because we have not, as a specialty, we have not yet come off the, it's still being managed by general surgeons, so that's evolving. Mastitis is inflammation within the breast tissue, and it can have infectious etiology. It's broadly divided depending if it's coming into a woman who's lactating or not. In lactational mastitis, it arises as a result of milk stasis within the breast. Milk is great culture medium for bacteria. Many women who are breastfeeding will have multiple episodes, but it has a huge spectrum, because you can have a woman who settles on 2 or 3 days of, on a short course of Fluclox at home, and you can have a woman who will present on your take, going into septic shock. Staph aureus is a frequent culprit. Start Fluclox early. And continuation of breastfeeding is encouraged, because if you imagine basic principles of sepsis management in terms of sepsis management and source control, if there is no abscess, you want to keep the milk flowing so that it's not stagnating in the breast and potentially resulting in an abscess. Periductal mastitis, on the other hand, affects the subareolar ducts rather than the breast tissue itself. Often there is inflammation. There can be infection up to 85% of cases, and often abscess formation with rupture of the affected duct. And it is almost nearly always a disease of smokers or ex-smokers or nicotine users. Vaping does contribute. And a little asterisk, because the consequences of this a lot of the time can be mammary duct fistula, and it's a difficult disease to manage. There's wide spectrum of causative bacteria, but often there is anaerobes, therefore use Comoxiclav. Breast abscess you will think of if the patient is presenting with persisting or localized symptoms, and prompt assessment is needed to exclude an underlying abscess, because they can destroy breast tissue quite quickly. If there is an option for first-line management, or if the question says most appropriate management step, you want to get a breast ultrasound. And it's not just if it's clinically obvious, because if you've got skin necrosis and you're worried about someone overnight, you may have to stick a knife into it to drain it. But if the patient is reasonably well or the skin is not threatened, you get an ultrasound, because it is useful to exclude further foci to ensure complete drainage. And our breast radiologists can aspirate with ultrasound guidance away from the skin to give better cosmetic outcomes once healed. And it's treatment with aspiration of pus from any collection on the local anesthetic. It says rinsing of cavity with local anesthetic, and that particular book depends on individual practices. But it can be performed on repeated occasions, and it usually lets the breast settle without scarring. Small stab incisions with 15 blade on the local or formal IND under general anesthetics are possible, especially the small stab incisions, and a formal incision and drainage may be needed. It is rarely needed, but it can be an important tool in the surgical toolbox. This is the Exeter guidelines for breast sepsis. So Fluclox first line, Clinda and vancomycin second line if penicillin allergic, especially very septic. For lactational, it's flucloxacillin or clindamycin if penicillin allergic. And periductal, you'll notice that it's Comoxiclav first line. This is a picture of mini incision and drainage that can be utilized with appropriate drainage of sepsis without too much of a cosmetic consequence. I've stuck to time, yay. But there's so much more. I haven't gone into details about DCIS because it varies. I haven't particularly mentioned every single genetic mutation, but BRCA1, BRCA2, and PDL1, there's some other ones that you will need to know as a senior breast trainee. all the information is out there. Yes, so please don't take this as Bible. Go read the NICE guidance. If you're interested and if you've got time or